Good evening, everyone. Welcome to our annual members meeting. I'm Sam Dalton, Events and Membership Officer here at UHS, and I have just a couple of housekeeping points before we start. So we've collated the questions which are submitted via the registration form. To ask a question not already submitted, then click on the question mark chat icon in the top right-hand corner of your screen on the row of icons, as you can see highlighted here. And if you click on that icon, the Q&A chat channel opens. And you'll see highlighted at the area at the bottom of the chat channel, click here to ask a question. Type your question in the box and tick the post as anonymous box if you do not want your name to be added to the question. My colleagues Rachel and Karen will be going through the questions and we'll look to get to as many as possible during the Q&A session. Finally, we hope all goes well technically, but please bear with us if there are any hiccups during the meeting. And I'll now pass you over to Jenny Douglas-Todd, Chair of the Trust Board.
Thank you very much, Sam, and welcome to all our members. We know we've had quite a few of you registered to attend today, so we're really pleased to be with you here this evening. It's virtual, so in some ways it would be nice to be in the room, but I guess being virtual means that many more people have the flexibility and the luxury to attend. So a big welcome. You're going to meet many members of the board today and other senior members of the trust. It was just a year ago that I attended this members meeting virtually, my first as chair. So I'm pleased to be back here this year, and actually pleased in that time that we've had quite a bit of interaction with you as members, particularly in relation to the appointment of individuals to the Council of Governors. We had quite a significant change last year with 10 new governors being appointed, and we've had more being appointed this year. So it's a really big thank you to you as members that we can make sure that the Council of Governors continues to flourish and that we have some quality people coming on. Because of time, I'm not going to say anything more at this point, because I think it's more important that you hear from the individuals who are going to contribute. And what we're going to do first is to go through and get some highlights from the annual reports and accounts. And I'm going to hand over to David French. I'm sure he needs no introduction, but David French, our Chief Executive, to take us through the first few minutes. David.
That's great. Thank you very much, Jenny, and good evening, everyone. And thanks very much for joining this event. So I'm just going to spend a few minutes just going to give a quick overview of the initially the trust and then some of the highlights for the year. So next slide, Sam, if you would, please. I'm sure many of you are familiar with who we are as an organisation. But just in case, so we're a really large hospital. I think we're either 9th or 10th in the country, and many of those that are larger than us are actually split over many sites. So we're one of the largest in the country on our single site here in Southampton. And Ian will take you through some of the numbers later, but our turnover is in excess of 1.2 billion pounds. We're both a district general hospital providing local services to our local population, providing everything that you would expect a local hospital to do. So from the very benign routine work, so if you need a hernia operation, if you need you've broken your arm, something like that, we do all of that. But what we also are is a regional tertiary referral centre. What that means is that if you are referred to your local hospital in the region with something that is not something that they can do, so I'm thinking here of things like brain surgery, heart surgery, major cancers, that sort of thing, then you will be referred from your local hospital here in Southampton. And as that regional hospital, we're serving nearly 4 million people across much of the south of England. And we make the point there that we're one of only 2 major trauma centres in the south for both adults and children. In the UK, trauma is classified according to severity, and the highest level of trauma is reserved for one of 13 trauma centres across the country, and we're one of those. What that means in practice, that is, if you're unfortunate enough to be in a really serious road traffic accident, for example, you will be scooped up by either ambulance or helicopter, and in many cases you'll be driven past other hospitals. So if, for example, you're on the M3 north of Basingstoke, the ambulance will drive past Basingstoke Hospital, past Winchester Hospital, and they'll bring you here. And that's because 24 hours a day, 365 days a year, we've got teams of experts that can do just about anything to a really high quality standard. As a university teaching hospital, we're big into research, and I'll make a couple of remarks about that later, but we are one of the highest recruiting hospitals to research clinical trials as well. Thanks, Sam. So just to give you an idea of the scale, these numbers are in annual, and sometimes it's easy to think. I think it's easy to think about daily numbers, but we have 40 theatres. So every day we've got 40 theatres running. We have around 2,500 outpatient appointments every day. We have between 400 and 450 people coming to our emergency department, and we've got more than 1,000 beds. And I mentioned we provide local services and regional specialist tertiary services. The split is about 50-50 in terms of our bed base. And that map on the bottom right hand corner, how we are delivering outpatient clinics across the south. Actually, we go as far as Plymouth, and we go up to Oxford and beyond. So that regional service is really quite broad in terms of the geography. And actually last year we provided service for patients from literally all over the country. The country is split into 44 NHS regions, and we had patients from every single one of those 44 regions that were coming here for treatment last year. Thanks, Sam. These are the values that we we talk to everybody who joins the organisation about what our values are, and it's the North Star, if you will, what guides us in every decision that we make and every interaction, every encounter we have, both with each other and with patients. And I would like to think that you could stop anybody, any staff member in the hospital, and ask them what those values are, and they would be able to quote them, really deeply embedded and at a practical level, impacting how we operate as an organisation. I won't go through them all, but Patients First speaks for itself. So it's around the quality of outcome, the quality of the patient's experience, and making sure that we're safe at all times. In terms of working together, this one has changed really over the last few years. We used to interpret it as meaning working together within the hospital, but now increasingly the NHS is collaborating rather than competing. So that working together concept means how we interact both with other NHS organisations, but local authorities also on social care, and universities and charities, that sort of thing. And then always improving. That's about our hunger to get better. So I think we're a great hospital already, but what we're trying to do every day is be even better than we were today, even better than we were the day before. So it's let's not be satisfied with what we're doing. Let's keep on improving all of the time to get better. Thanks, Sam. A couple of highlights that I'd just like to pick up. You'll have seen a lot of the media covering the waiting lists across the country, and one of the challenges from government to the NHS was, after the COVID pandemic, how do we get back to recovering our scheduled work, our outpatients, and our scheduled surgery, so that we can start to attack the waiting lists. And we compare a lot to year 1920, and frankly that's because COVID was in between. So year 1920 is the best year that we had to compare against without COVID. And I'm really delighted that in year 22-23 last year we achieved 8% more activity than we did in that pre-COVID year. Comparing to the national average was about 97%, so 3% less. So us doing 8% more placed us in the top handful of hospitals in the country, and that's something I'm really very proud of. I'm also really proud, every year the NHS does a survey of every member of staff, You can't get not everyone will fill in the questionnaire, but we had close to 60% that did, and actually our results were 7th best in the country. So really outstanding results. Doesn't mean that we're perfect. There's still things that we need to work on, but compared to others, our staff were recommending us as a place to work and recommending UHS as a place to have treatment. Leading the way with research, so we've launched a couple of new specialised services this year. We launched something called CAR-T, only a few places in the country that's doing that, and also our cardiovascular and thoracic teams were the first in the country to use 2 robots for operations running simultaneously in the same hospital. We chose as an organisation to invest in R&D. We launched a 5-year programme. I think we're in last year was year 2 of that, and we're seeing the benefits of that starting to come through. So our research income for the year was £45 million, really impressive. We've spent significantly, and Ian, I'm sure will cover this in his presentation later, on upgrading the estate. It's a large estate, and we didn't have enough capacity, so we've invested in new theatres which are up and running, and we've also, thanks to the Banksy painting money, been able to build and open a new wellbeing hub for staff. It's a really fantastic facility and a once in a generation opportunity for us to build something like that ordinarily we'd not been able to do. So we're really grateful for the donation from the Banksy, the Banksy painting gave for us, and I hope that he agrees that we've made really good use of that money. And at Adanac Park, which is a site about 2 miles away towards the M271, for those that know the area, it's by the Holiday Inn at junction 1 of the M271. We've got a 10-acre site. The first building that's gone up is a park and ride car park, which has consolidated all of the off-site parking that we had for staff because we haven't got enough capacity on site. So that's up and running, and it's a really great facility. And also on that site, the next building that we're doing will be an aseptics unit that will be providing aseptic chemotherapy treatments for this hospital and for the region, and also a new sterile services facility, which will upgrade the fairly aged facility that we've got on site and release that on-site space for clinical work, with that work then going instead to Adanac Park. And I understand Emma Northover, who's a fantastic director of midwifery, is making a presentation later about the maternity service, but the service was inspected by the CQC fairly recently, and we got a good rating. And actually, given what's going on in maternity, I think good is a really outstanding result for us, and we're really proud of our maternity service here. Thanks, Sam. So, if you read the news, listen to the television, it's beyond doubt that the NHS is under serious pressure and serious challenge right now. I won't go through all of the points on that diagram there, but what I would say is we've got a workforce under pressure. They're under pressure personally because of the cost of living crisis, and although inflation is easing, prices are still going up. Most people in society faster than their income, and that is certainly true in the NHS. But there's professional pressure as well. Industrial action is causing divisions within teams. Some people choosing to strike, some people choosing not to strike. And whilst that's a matter for government and union to sort out from a trust perspective, we urge the parties to get together and try and reach an agreement so that we can resolve the industrial action. As I say, it's unhelpful for us as an organisation in terms of a united workforce, but critically, when we're having industrial action, it means that we need to reduce the amount of activity that we can do, and that means that we're not able to get the waiting list down as quickly as we want to. Thank you, Sam. So what are we doing to tackle these challenges? I think despite all of the pressure, we're really keen to maintain the quality of care and service that we provide for patients. And Gail, our chief nurse, will cover that in some remarks that she'll be making later. Collaboration, I mentioned that word before. We're moving as an NHS from competing for patients, competing for resources, into a more collaborative single NHS organisation. And actually, I think there are real benefits for us because we've got a capacity shortfall. Even though we're doing a lot more activity than we were before COVID, we still have a capacity shortfall, and we need and are networking with other local hospitals to make sure that the demand that we've got on our services, we've got ophthalmology patients being treated elsewhere, we've got urology patients being treated elsewhere, and that helps us get that waiting list down. I'll mention briefly the Southampton Renaissance Board, which is a partnership really of major employers in the city, of which we're one, alongside the universities, the City Council, Associated British Ports, those kind of organisations. And what we're trying to do is work out how we can make Southampton a better place to live and work. It's about how do we improve the standard of education, how do we improve the standard of housing. So by bringing all of those agencies together, I think that will have benefits not just for the city, but it'll have benefits for us because it makes our recruitment challenge easy. And actually, if we can improve poverty and deprivation in the city, that's good for long-term health of the population, which in turn benefits us. We're using technology where we can, and some innovative stuff that was made here, as well as things that we've bought. So My Medical Record is is software that a patient can use themselves to monitor their results and get in touch with us if their results are going off track. And so we're moving from a more historic model of an outpatient appointment every 3 months to something where the patient is in control of their condition and is telling us when something is going off track, off plan, and interacting us through a digital medium rather than through letter and traditional outpatient appointment. I won't say anything more about money because I'll let Ian talk about that, but I can't let this moment go without referencing a £30 million grant that we've received from central government to decarbonise the site. So that will be about how we make the site, which is predominantly 1960s and 70s, far more efficient, so that we drastically reduce our dependency on carbon. That will mean that we're converting from steam to create heat and energy through to far more efficient low temperature hot water. And we'll also be putting PV solar panels, more of them on the site. There's some already, we'll be putting more on. But that £30 million, again, once in a generation opportunity for us to make really significant improvements to our green sustainability. Thank you, Sam. So I'll wrap up there. But when I stand back and think about the organisation, it's all about the people. And there's some people shots here of some of our staff receiving rewards. So in the middle at the top was a national event recognition for our urology team, and on the top right was the UHS colleagues at Westminster Abbey celebrating the 75th anniversary of the NHS. And one of our paediatric critical care consultants on the left of that photo was asked to speak because he led the repatriation of Ukrainian children following the Russian invasion of Ukraine. And we brought, under Michael's leadership, we brought back paediatric children with cancer to the UK so that they can continue their treatment. So that made me proud, and there are so many things that are happening here every day, all of the time, that make this a fantastic organisation. We have amazing people doing amazing things, of which I'm extraordinarily proud, and thank you for listening. And Jenny, I'll hand back to you.
Thank you very much, David. And I think that's a good segue into us hearing from some of your team, some of your top team that enable this organisation to do amazing things. So I'm going to go to Ian Howard first as the Chief Finance Officer, and then straight Ian will take us through the annual accounts. And then Gail, if I can ask you to be on standby when Ian's coming towards the end to take us through the quality accounts. And Gail Byrne is our Chief Nursing Officer. Ian.
Thank you, Jenny, and good evening, everyone. I'm Ian Howard. I'm the Chief Financial Officer here at UHS, and I was just waiting for the slides to go up. Thank you, Sam. So as Jenny said, I'm just going to take you through the finances of UHS at the moment. And I guess David was very clear on some of the pressures facing the NHS and some of the issues and challenges that we're facing at the moment. And I couldn't start the finances without highlighting some of these pressures and how they also have an impact on the financial position of trusts up and down the country, including ours. So we've got the impact of industrial action, which I'll touch on later. Impact of energy prices and the cost of living and inflation is having an impact both on our staff but on the trust finances as well. We've got workforce challenges. We struggle to recruit in certain areas, and that means we've got too much reliance on temporary workforce. And whilst a level of temporary workforce is valuable to the trust and gives us flexibility, it does mean it does come at a higher cost for us, and we're too reliant on that. And obviously and you'll see in the press very regularly the impact of waiting lists on hospitals, and we know people are waiting too long for treatment. And we have the same here at UHS, and we're obviously trying to address that, but that has financial consequences as well. That's sort of the external environment. Sam, if you move us on to the next slide, probably pause on this slide for a little while. So I guess headlines here are that the trust, as you can see, historically have been a financially very successful organisation, and we've delivered surpluses and built up cash reserves, and we've reinvested those cash reserves in hospital infrastructure. So the capital programme that David talked about, that we've been delivered this in 22-23, we spent around 88 million in capital on new wards, new theatres, equipment replacement, backlog maintenance, digital infrastructure and diagnostics equipment. So we really have invested a lot of our historic cash in improvements across the hospital, delivering some fantastic healthcare facilities. However, a number of our facilities haven't been addressed with new capital spend and are aged and need further investment. So that's the challenge of the trust at the moment, is we've got areas of the trust that are really well developed and modern to modern standards and new, and areas that unfortunately aren't at this point in time. We've been facing significant operational pressures, including regular waves of COVID and other seasonal illnesses in 22-23. But despite these pressures, as David said, we were able to deliver 8% more elective activity than at pre-COVID levels. So we have managed to increase activity levels, and we continue to focus on that as a priority. We did fall into deficit, unfortunately, in this financial year. So we did move into an £11 million deficit for the year as a result of a number of the pressures that I've outlined earlier in the slides, including energy costs, which hit the trust quite hard. I didn't want to pause at 22-23 because I'm conscious we're now 6 months into 23-24 and things move on quite fast in the NHS. So I just wanted to give a few headlines of where we are as a trust, and I just wanted to start that with some national context. So we started the 23-24 year with some financial headwinds from 22-23, and nationally we also had reductions in funding from previous non-recurrent funding given to us for things like COVID-19 and also efficiency targets for the NHS as a whole, as well as targets to increase the level of elective activity that we're undertaking in order to tackle those waiting lists. And I guess in year we've also seen the challenge of industrial action, and as at month 4 we had seen a £1.1 billion pressure across the NHS, both in terms of the cost impact and the impact value of lost activity as a result of industrial action. And that's from the published NHS England board report in month 4. So we do have a nearly £1 billion deficit in the NHS in the first 4 months of the year. And I guess that context is important because that is reflected in the UHS position for 23-24. So we planned for a deficit of £26 million, and we have had those headwinds of industrial action, as well as some of the inflationary pressures and challenges on our budgetary position. And as part of Hampshire and Isle of Wight ICB, we did enter the National Recovery Support Programme to ask for help to address some of these challenges. That said, we are still focused on maintaining the quality of care, as David alluded to earlier, and we are still trying to increase the activity levels that we're undertaking. And in the first few months of the year, we were at 115% of pre-COVID levels, and that was within the top 6 nationally of trusts in terms of the level of activity that we're able to undertake. And that's really as a result of that capital investment that we've maintained over the last few years, giving us additional capacity to be able to treat more patients. Sam, if you wouldn't mind flicking on to the next slide. So this slide just highlights some of the underlying financial pressures that we're seeing as a trust. So whilst we are currently forecasting delivery of our 26 million plan, that is under significant pressure as a result of a number of issues, notably industrial action. We've also had increases in demand in our emergency department, and particularly for patients requiring additional support to meet mental health needs. And we also have a number of patients in our hospital in beds who could be better treated and better looked after outside of the hospital setting, but we're unable to discharge them to an appropriate setting, so they're within our hospital bed capacity, and that's causing us challenges in terms of patient flow and activity and funding levels as well. If we just move on to the next slide, Sam, nearly there on slides. I'm trying not to do death by PowerPoint. So what are we doing about it? So we're continuing to focus on activity levels, on quality, on finding our top speed. So how much elective activity can we deliver? We're focused on our cost improvement programme and delivery of that. We've got really good identification of our cost improvement programme for the year, but the challenge is some of those areas are difficult to deliver. So we are working on that. We've got transformation programmes within the trust focusing on improving how we deliver outpatients, improving patient flow through the hospital, and making sure we're optimising the use of our theatre capacity. And we're also working in partnership across the Integrated Care Board. So we've got 5 transformation work streams across the ICB, focusing on planned care, urgent and emergency care, local care, discharge and workforce, as David alluded to, moving away from the historical sort of competitive approach to more collaborative. How can we improve care for patients? How can we improve patient experience, and how can we make that experience mean we're operating more efficiently as a healthcare system? And then finally, just wanted to end on some on a more positive note. So despite the financial challenges, if you look at across all benchmarking on national data, and albeit this is a year out of date, but it hasn't changed massively for the following year, we are performing in upper quartile in terms of our productivity. So we are able to produce high quality levels of activity and high quality services and for a really good cost. It's cost per weighted activity unit. It just means cost per unit of activity that we're able to undertake. We are a very efficient and good hospital financially, but despite that, with the pressures, we are struggling, but we are still aiming for improvement and always improving, as David said, one of our most core values. We are trying to do it every incremental step we can take to improve services for patients and finances at the same time. That's what we're focused on delivering. I'll pause there. Jenny, back to you, I think.
Thank you very much, and that's an apt time to bring in Gail, who's our always improving lead, who will take us through the highlights of the quality report. Gail.
Thank you, Jenny, and thank you to Ian and David. And yes, I'm Gail Byrne. I'm Chief Nursing Officer here at UHS. If you see me a bit distracted, it's because I've got a fly in the room that's buzzing around and keeps bombarding me. He obviously wants to really listen to our AGM here, so apologies.
Gail, I don't know if you know, but at the moment we can't actually see you. You're not on camera.
Can you see me now?
I can't, no.
Oh.
But carry on, we can hear you. Try turning your camera off and on again.
After this, I'll come out and come back in again.
Yeah, okay.
So thank you, Sam. Next slide, please. So quality count, like the finance count, is published every year. It's been published since 2010. And it's really about making us more accountable for quality to our patients and the public. And it helps improve and drive that improvement process and transformation process in the quality of our services. So thank you, Sam. Yeah, there are three parts to the quality account. So the first is a statement from David on our quality. Part two is a retrospective look at last year's quality priorities and how we did against those quality priorities. And then part three is identifying what our future quality priorities will be for the next year. We also have statements from our clinical commissioning groups, ICB, our local health watch, and the overview and scrutiny committees. So they will make a statement based on what they have seen of the organisation and the reflection of that in the quality account. Thank you, Sam. So these were our quality priorities, and I'm not, because of time, I'm not going to go through them in detail, but they certainly will be shared as part of the AGM. I think in reflection, one of the things that it has been a very challenging year. It's been a challenging year still with COVID at the early parts of the year. It's been challenging through a very, very challenging winter last year. And also strikes, as has been noted, and that feeling of resilience in the organisation. And I think that given all of that context, actually we should be very proud of the quality priorities that we've achieved. And actually those ones that are partially achieved, it's not that they won't be, it's sort of that is an iterative process, and actually what we'll be looking at is making sure they are delivered in the future. So you will see where we've put partially achieved, we'll be putting action against that. So for example, that number 3, the mental health strategy has been finalised. So you could move on the slides there, Sam, thank you. And again, I think there is so much that's been achieved here. Shared decision making led by our Chief Medical Officer in terms of ensuring people have a voice and empowerment to make their own decisions about their own health. So those are all things, and you can see that actually we had 8 priorities. What we have done now is try to reduce those, because I think it's better to focus on less and focus deep rather than wide, if that makes sense to people. So you'll see our quality priorities as set out, Sam, on the next slide. The first one is around improving care for people with learning disabilities and autism across the trust. Then quality priority 2 is supporting patients to overcome their tobacco dependence via a smoking cessation programme. Our next priority is ensuring carers are fully supported, involved and valued across our service is really important, because carers do all of the care at home, and actually we need to ensure that they're empowered to deliver that care as well, if appropriate, whilst patients are in hospital. Next slide, please, Sam. And priority 4 is putting the patients at the centre of what we do, enabling their voices to improve the quality of care. And I think there is a question on patient experience, so I'll go into that in more detail a little bit later. And then developing our clinical effectiveness process, and using our always improving, as Jenny said, our transformation to measure, understand and using our outcomes to improve our patients' care. And then developing a culture where all clinical staff have a basic knowledge of diabetes, and people will possibly be aware that diabetes has grown substantially over the process of the pandemic. So those are our 6 priorities, and what we'll be doing with those is making sure we measure them, making sure we then report on progress, and the final piece will be next year when we report on them in the quality account. And with that, Jenny and Sam, I have finished. Thank you.
Thank you very much.
I'll log off, Jenny, and then I'll try and get back with my camera.
That's fine. And we are going into the Q&A now, so
Yes.
so it'd be great for you to join us for that. So can I firstly thank David and Ian and Gail for their contributions and their oversight and highlights from the annual report and accounts. We are going to be joined by Steve, who is our Chief People Officer, Steve Harris. I think I mentioned that earlier. And we are therefore available. We have a panel available to answer any questions that you might have. I know Rachel has put a note into the Q&A. If you do have any questions, please put them into the Q&A and we will ensure that they go to the panel. Some members had sent questions in ahead of today, so I'm going to go to those questions that we have until more come into the Q&A section. So the first question that we have, and I think I'll direct this one to Ian, is what percentage of purchasing spend takes advantage of national NHS purchasing power?
Thanks, Jenny. Yes, and thanks for submitting that question in advance, because there's a detailed percentage asked. There's different ways of looking at our expenditure, but when if you include drugs, medical supplies, blood products, etc., we utilise national spending power on about 60% of our expenditure. For the remainder of our expenditure, there is a relatively new tool called the NHS England Spend Comparison Service, which is used by our procurement teams, and that ensures we get best price paid for an item within the NHS and make sure that's accessible to UHS, so we can see the prices paid by organisations across the NHS for every product. So we utilise that for local spend decisions as well. So even where we're not utilising national purchasing power per se, we can ensure we're matching the best prices across the NHS.
Great, thank you, Ian. And Gail, it's great that we can actually see you now. So you're on screen, and I'm going to go to you for the next question, which is one that's been put into the Q&A this evening. It is, are there any targets set for the quality priorities, and is there a baseline to compare them?
Yeah, sorry, but I wasn't clear. Probably the fly was buzzing around my head. But yes, what we will be doing is we will be having a baseline where we can have a baseline, and then we always develop measures against those quality targets. Some of them are softer than others, but we do measure it, and that's how we monitor our progress. So yeah, that's a good question.
Thank you very much, Gail. And I'm going to go to you, Steve, for the next question that was given in advance. So as the Chief People Officer, you're probably the person that's most fit to answer this, although of course recruitment and staffing sits right across the organisation. But do you have plans to address using less bank nursing services?
Yes, we do. I think Ian made the point in his presentation that a contingent workforce is a really important part of an overall workforce. So having temporary staff to rely on is really important. The challenge has been at the moment that we've been probably using more than we'd like, and that's been driven by vacancy and hard to fill roles. If we think about where our largest spend is in the organisation, it's around our nursing roles and our healthcare assistant roles. And over the last few years, the recruitment team, working in partnership with the senior nursing team, have been really successful in our nurse recruitment programs, and we've taken our vacancy rate from around 19% down to about 9% now, with our hope of getting it to about 5% at the beginning of next year. And our ultimate goal is to basically fill as many vacancies as we have as possible, and therefore reduce the amount of reliance that we have on bank and agency. Agency obviously being the most expensive one, and that's where we've been, really successful working with the nursing team in driving out particularly high cost agencies like Thornbury. So that's basically our plan, is one of conversion, recruit substantive staff to replace the bank and agency that we have. Again, I know you've been doing a lot of work in this field as well. I don't know if there's anything you wanted to add from a nursing perspective.
Yeah, I think so. One of the things having in my tenure, which is coming up to 8 years actually, our vacancy rate has never been as good, as in it's low, and we've got more newly qualified coming in and more overseas. So one of the things that I'm doing with my senior nursing team is we've set up an operational group to look at how we can reduce our bank and agency, and we've got a whole action plan which we've got leads for, and looking, for example, forensically about what is hygienic or good rostering, so on a ward, so making sure there's only so many people on holiday, for example, making sure that one shift isn't left with gaps where another is over. So that there are certain things that you can do with good rostering, and we're going to be overseeing that as a senior nursing team. But there's lots of other things, like making sure that people know around their budgetary control and what they can do. And we manage staffing very tightly on a daily basis through our staffing hub. So the issue is about reducing the bank and agency, keeping staffing safe, because at the end of that is patient care, but making sure that we deliver more cost saving as appropriate to do, because of the financial challenge that we find ourselves in.
And just to add, Jenny, obviously recruitment is really important, but the flip side of the coin is retention as well. Obviously, the more people we lose in the organisation, it's more people to replace, and we work really hard as a senior team to continue to make UHS to be a great place to work, one where our staff, thrive, excel and belong, as part of our people strategy. I mean, the more people we can keep, the less we have to recruit, and the more people will then be advocates about what a great place this is to work.
Great. So I'm going to move on because we've got quite a few questions coming in now. Gail, I'm going to go to you first on this, but others might wish to come in. So does the empowerment of carers mean that they will be expected to care for the family member while they are in hospital?
No, not at all. That's not sort of the thing that I was getting at. But if they wanted to, that they could. They are actually the experts in their family members. They know better than the nursing staff their family member. And so I think it's about empowering them to have that responsibility within the ward environment, and certainly not precluding them from coming in if they wanted to. And I think that's really important, and particularly for example, when we mention about learning disability, it's about making sure that carers who know that person, who, even though we might have a passport about what their likes and dislikes are, the carer knows them best, and we need to listen to them. That, I think that's what I'm saying, not that I'm expecting them to come in and deliver the care.
So that's about us being more flexible and responsive to the individual's need and their families. Ian, I'm going to come to you for the next question, which is around the 8% activity increase that we saw in 2022-23. And I think both you and David mentioned that it's now at 15%. And this question, Civil Law is saying, the 8% activity increase is fantastic. What is the yearly target to improve the activity levels?
Yes, so in 22-23 we had a target to increase activity levels by 4% across the NHS, so 104% of pre-COVID levels. And in 23-24 that's increased across the NHS to 107% of pre-COVID levels. And so far this year, we're at 115%. We had a slightly higher target than the 107% because of our higher activity levels. The previous year we were given a bigger stretch. The target was about 109%, but we are exceeding that as well.
So David, I'm going to come to you for what is a topical but technical question, and it relates to the 24,000 unsigned and unsent letters that were found in the computers at Newcastle Hospital. You'll remember this was all over the news last week, and the 400,000 unsent letters in Nottingham Hospital computer. So the question is, have we looked at our own organisation to see whether or not we are in a similar position with letters unsent? Do you want to take that first? And if you want to bring somebody else in to assist you with the response, please do.
Yeah, no disrespect to exec colleagues. I think this is probably me, because Joe's got a responsibility for IT and he's not here. But let me have a go at it. So I think the first thing I'd say is that I think across the NHS everybody recognises that this is a completely unacceptable and unsatisfactory situation to be in, where results and clinic letters have not been posted. The second thing I'd say is that Newcastle use a completely different system to us, as do Nottingham. I think one of the challenges in the NHS is, how do you make what we would call closed loop? Now we do make reviews of where a patient, for example, is seen in clinic. We do monitor what has the outcome of that clinic been. That said, it is possible in any system for it not to be 100% foolproof, but I can say with confidence that we do not have the situations that have emerged at Nottingham and Newcastle. Just to be completely transparent, we did have a situation a few months ago where there was a delay in letters going from here to GP, and our systems caught it. So because of those checks, we clocked that the letters hadn't gone out, and there was a technical issue when we released the letters and they were a week or so late. But it gave me some reassurance that if something was to happen like that, then our monitoring systems catch it.
That's really helpful. And David, I'm going to stick with you for another question that was sent to us in advance, which is around physician associates. So the person that submitted the question wanted to know, do we have plans to introduce physician associates to UHS, assuming they're not currently working in UHS?
Do you want me
Steve,
to
I
take
can
this
see
one?
you're itching to jump in, so I'll let you with pleasure.
So
And I think Gail's got her hand up as well.
So physicians associates, just for people's benefit on the call, these are essentially roles that have been created that work alongside medics, people who've come from, say, scientific backgrounds, etc., undertake a training program and then will work supervised under a medic and can take on some responsibilities unsupervised, due to be regulated by the GMC from 2024. In UHS, we've made quite limited use of these. I think we've only got a couple across the organisation, and that's primarily because of the composition of our medical workforce and also the composition of our wider healthcare teams. So we've traditionally done very well in recruiting to additional medical roles from overseas. We've had a really successful fellow program where we've augmented our junior doctor rosters with medics from overseas that we retain and then hopefully go on then to transition to onto a formal training program or into more senior positions. We also make really good use of our wider healthcare workforce. So we have, for example, highly specialist nursing roles called ACPs, advanced care practitioners, which work alongside our medical teams. We've got well over a couple of hundred of those in the organisation, and again they help to provide and support our medical staff with the work that they do. I think the future around physicians assistants is really interesting. It's part of the National Workforce Plan. I think once that really starts to bed in, we'll start to see what opportunity we have to grow those roles going forward. But to date, it's been something we haven't really used, as I say, in any sort of expansive way at UHS.
Thank you very much, Stephen. That's quite a detailed response. So, Gail, I'm going to come to you with a different question, particularly as you are the lead. Infection prevention sits under your leadership. So, how much more could be done to address infection control? So it's just dropped off my screen. Especially as we head into winter, and it adds to the system pressure so much in terms of staff and patient impacts.
Right. Yeah, I think I've got the question in front of me. So one of the things that people observing will possibly know about is we ran a very successful COVID zero campaign here in the trust, where actually we had for a teaching hospital very low healthcare associated infections. So what I mean by that is infection being spread within the hospital, and that was really important in COVID, because what that meant was that we didn't have some of the numbers where other hospitals became overwhelmed. And the infection control team is to make sure that actually we still continue with robust infection control measures throughout the trust, that we respond to infections as they're happening, as in COVID, and what we do about that. We respond to national guidance and ensure that often we make then a decision about and we've often gone above national guidance to protect both patients and staff. And so going into winter, there is a new variant of COVID, and I would encourage people to take their flu, influenza vaccination and their COVID vaccination in the public, because that protects not only yourself but also those around you. And we'll be watching out for norovirus, and we'll put all of the measures in and respond accordingly. So I think there is oversight. I think the way in which everything's gone away from an infection control perspective. Well, it hasn't here within the hospital, is what I'd say.
And it's been really evident over the last year or so, hasn't it, how the
Yeah.
focus on that has had a really big impact for our hospital and patients and staff working within it. So Gail, I'm going to stick with you, but Steve and others may want to come in on this. It's a question around the patient satisfaction levels. So what are they? What does the PALS data tell us, particularly in relation to broader diversity within the city?
Gosh, I can't see that question, but
it's not been published yet, so it may well come up now.
Okay.
So what are the patient satisfaction levels using the PALS data, and what particularly does it tell us in relation to diversity of the city?
Interesting. So the first thing I would say is that we've just had our patient satisfaction survey, which is our annual survey. I think in the region, actually our score for patient satisfaction went up, only slightly, but it went up. A lot of trusts' patient satisfaction has gone the wrong way. So I think that is really important. One of the things in terms of what we're looking at, and unfortunately I wasn't able to attend the meeting today, is around health inequalities and how we look at health inequalities from a diverse perspective. And I think that that in terms of our local population is making sure that we serve our local population and ensure that we look at any health inequalities that happen through protected characteristics. So our PALS team, actually we've just got a new head of patient experience. We've also, I should have mentioned earlier, got somebody who leads in terms of carers within that team. And I think that we are taking the opportunity with Jenny, who is a senior nurse by background, but absolutely is innovative, is to actually step back, listen to what patients want from us. Listen, we've got patients as partners as well that we work with, who work within patient safety and transformation, and actually stop and look at what matters to people, what matters to our local population. So there may be an element of that question that I haven't answered, but do feel free to come back at me.
Thank you. Does anybody else want to add anything to that, or can I move on to a couple more questions?
Just
David?
a couple of comments from me. So first of all, I see all of the complaints that come into the hospital, and actually I think the some areas of the city are probably underrepresented in the complaints. It tends to be the more prosperous, if I may use that word, patients that are writing. So there's something about how can we encourage feedback from all groups. We did, as an exercise, look at whether specialty by specialty, some patient groups were experiencing a worse level of service from us, in particular the waiting times. Actually, we saw no correlation at all between ethnicity, social deprivation, and the waiting times. We did recognise, though, that that's a function of when the referral comes to us, and there may well be inequity in the part of the patient pathway before the referral comes to us. But in terms of how we are seeing people, statistically it was there was no discrimination or inequity.
So there is a follow-up question on that one, which is, could we have place demonstrative figures in the next annual report. That's something we can take away and think about. But as we've got time for about one more question, I wanted, if I could, to stick with you, David, and ask the question around that came in beforehand. What are our plans to be a smoke-free hospital?
Yeah. So there are plans, and very recently, in fact, it was just 2 weeks ago, Jenny, we signed the pledge for the hospital to be smoke-free by April, and that's a commitment that we've made. Paul Grundy, who's Chief Medical Officer of the Trust, is leading that from an executive standpoint. So what are we doing to get to smoke-free by April? So the new signage going up, reminding that there's no smoking. We're phasing out the smoking shelters, in particular the ones at the front of the hospital. And I know because that causes a lot of complaints and consternation. We're setting up staff engagement sessions for staff that smoke to encourage them to stop smoking. And actually, of the smoking cessation programs that we have run, the success rate, i.e. those who have permanently stopped smoking, has been really impressive, actually at 53%. What I should say, just to be again completely open and transparent, this has not been an uncontroversial topic. So there are extremes of views, and we recognise also that some people, whilst they might want to smoke, the reasons for their smoking is complex and multifactorial. So we've done it thoughtfully, and we've thought about it a lot before we've gone into this. Nevertheless, we've made the commitment we're going to be smoke-free by April.
Great, thank you very much. And firstly, can I thank all of the members who submitted questions, particularly whilst the question was on the question and answer session was ongoing. I think we covered most of them. If they're only in there that we didn't, then we will take an action to try and answer those outside of the annual meeting and get back to you. But also to thank those that submitted questions beforehand. And I particularly want to thank David and Ian and Gail and Steve for being willing to respond to the questions without any warning at all. So thank you very much for that. We're going to take a short 5-minute break. So if I can ask people to adhere to that time, just a short comfort break. We will resume back at 6:40 on the dot, and then we'll hand over to Kelly, our lead governor. Thank you. Feel free to turn your cameras and mics off while you're taking a break. Okay, so hopefully most people are back with us. And we are now going to go on schedule to Kelly Lloyd, who has been our lead governor for the last year. And I'm going to hand over to Kelly to update us, to give us a membership update. So over to you, Kelly.
Thank you very much, Jenny. It's my pleasure tonight to give you an update on our UHS membership and what we've done in the past 12 months. So if you could go to the first slide, please, Sam. Thank you. So what are the benefits of being a member of UHS? And probably the biggest membership I see is that you have an opportunity to help shape our trust. And in the last year, members have been invited to take part in several focus groups where we've been seeking their input and their thoughts on services such as phlebotomy, the shared decision-making initiative, and a new service that we've recently implemented to help inpatients and families feel empowered to escalate concerns. And also we sought a lot of feedback around the smoke-free site, of which we've just recently discussed. We also have an opportunity for those who want to be more involved with the hospital to become one of what we call a quality and patient safety partner. And that role is to provide their insight to ensure that patients' voices are heard and that they're always at the centre of everything that we do. We have a handful of those of the quality patient safety partners, and we're always keen to get more people involved. So if you would like to get in contact to find out more about that, we'll be really welcome that. We also have young members who we've been encouraged to join our Young Adults Ambassador group, and they've had the opportunity to give their feedback on the development of paediatric services and young people services. Another way that we engage is through our Connect magazine, and that's exclusive to members only. And we provide updates of what's happening across the trust, including the research that we do, Children's Hospital and Southampton as charities. Recent additions that we've had out have included interviews with governors so that members can find out more about our interests and why we decided to get involved with being a governor. This is a digital publication and we do distribute that once every 2 months. We've also delivered a number of virtual events over the past year, and they have focused on helping our members look after their own health and other people's health. And we've had topics such as men's health, heart health and diabetes. And these have really provided us with a great opportunity to hear from the experts within their fields and learning how we can look after ourselves and what support is available within the region. And feedback from such events have been extremely positive, and often we've tackled complex subjects which have been broken down in an easy to understand manner, and especially for those from a non-medical background. And for the first time, we've had the opportunity for public members to have their say on UHS Champion, with a membership award introduced at our annual staff award ceremony, which takes place tomorrow. We had an impressive 52 members submit nominations, and from publicly elected governors, and as I said, the winner will be revealed at tomorrow night's ceremony. But do look out for the full coverage of that ceremony at the next edition of the Connect magazine. And another reason to be a member is that you do get to vote for governors, and you also get the option to stand as a Council of Governor. Only members can vote, and only members can stand to be one. And in the last year alone, we welcomed 9 new publicly elected governors and 3 new staff governors onto our council. And as part of the Council of Governors, it's our role to work with the Trust Board to make sure that services are meeting the needs of our local community. And probably quite poignant in the cost of living crisis, all members do have access to the discounted website, which is the health service discounts, to get access to exclusive deals from hundreds of brands. So an added bonus for being a member. Next slide, please, Sam. Thank you. So we did get a question posed to us before this as, well, what does UHS gain from having membership? And so what we thought we'd answer this is by tailoring it to the 5 pillars of what makes UHS us. So the membership strategy was approved by the Council of Governors in July 2021, which was a couple of years after this, that the 5-year strategic plan was published. And one of the main objectives of the membership strategy is to support the trust in achieving each of these pillars within the 5-year ambitions. So I just want to give you a few examples of how membership engagement helps fulfil or feeds into each one of these pillars. So if I take outstanding patient outcome and safety experience first, we regularly invite members to take part in surveys and focus groups to improve the services, some of which I previously mentioned. And last year, we had the first cohort of those quality and patient safety partners were recruited, and we really value the contribution that they play to the governance and management of our processes for patient safety. And just to give you an idea, we do have 6 quality partners, and 5 of them are public members wanting to get more involved. And as I previously said, we welcome more on board to help shape our services further. And moving on to the pioneering research and innovation, we are regularly informed of opportunities to get involved in clinical research at UHS, and we publicise that through the Connect magazine and the Clinical Research magazine, which gets sent to all of our members. Moving on to the world-class people, membership communication promotes UHS as a place to work. Over 100 students signed up as members at our recent University Freshers' Fairs, and by keeping them up to date with what's happening throughout the Trust and highlighting positive experiences working at UHS, we hope that we attract them in the future when applying for roles after they graduate. Members also play a part in developing the future of our workforce by being invited to take part in student examinations for final year medical students. And moving on to our next pillar, which is the integrated networks of collaboration. One of our big ambitions under this theme is to champion health and prevention, reducing the inequalities in health alongside delivering the best healthcare that we can. Members' events have been focused to address these issues, such as last November's Men's Health Matters, January's Smoke-Free event, and the May's Diabetes Prevention event. So UHS is just one component of the integrated care system. So these events are often delivered in partnership with people such as the Southampton City Council, and the South Central Ambulance Service, who can add their own expertise. And finally, Foundations for the Future. Members, we encourage people to sign up to projects which support self-management of care, such as the My Medical Record. And last year, public members were invited to take part in a patient-led assessment of the care environment, and we had 46 members participate in that. So moving on to the next slide, Sam, please. Thank you. So what we've been doing this past year, we've been getting out into the community, which has been fantastic, because obviously during the COVID pandemic, membership engagement was limited to virtual events only. So now that the shackles of COVID are finally off, we've been able to get out into the community and had a full summer of activities to enjoy. And since May, we have attended 12 community-based events. Highlights of these include the Eastleigh Mellor Festival. We were due to participate in the Southampton Mellor Festival, but unfortunately, due to adverse weather, that was cancelled. We attended 2 Pride events, Pride in the Park and the actual Southampton Pride event itself. We've teamed up with Southampton City Council and attended a handful of Love Where You Live community events in central Southampton, Weston and Portsmouth are just a couple of those examples of locations. A Young Carers Festival. We had an event in the community Hindu temple event. We attended Southampton Child's Play Association annual play day back in August. We've recently had the Freshers' Fairs at both Solent University and the University of Southampton, and as of I think it was a couple of weeks ago, we had another men's health event that we attended. So it's been really great to actually get back out there and sort of engage with the community more. Next slide, please, Sam. So one of our objectives that we've really focused on, and it's kind of reflective from the type of events that we've participated in, So we want to develop our membership that is really representative of the communities that we serve. So what we've tried to do is, well, we see that we've got 265 new members have joined the trust, and we've tried to increase membership in key areas such as young people and people of a different protected characteristics. So that could be a diverse ethnic background and sexuality or sexual orientation. And you can see we've made some really good inroads there. We've increased 50% numbers between 16 and 29. Has a moderate increase in people between 30 and 39. The things that we've really performed well in is increasing 55% of our members who describe themselves as Asian British or Indian, and a 30% increase in members who are identify as Black or Black British or African. And due to the couple of prior events that we've attended, we've had good engagement with our LGBTQ plus community, and you can see we've got a third increase of our numbers there. So all positive steps in the right direction, but we know there's more to be done, so it's not like we're going to rest on our laurels there, and we'll continue that trajectory hopefully into the next 12 months as well. Next slide please, Sam. So things that we've got to look forward to, as obviously with autumn and winter coming, we'll probably be looking to turn to more virtual events. It's not obviously the great time of year to get out there and meet people in the open air. So we'll be looking at how members can look after their own and other people's health. We do have a carers listening event taking place in Romsey in next month, and we will be emailing out details shortly to our members on that. And we're also looking at further opportunities for members to help shape our future. So we will be reaching out to see if we can have some patient representatives to help us carry out our clinical accreditation scheme. So again, we've given our details there. So if there's anything that if you want to be part of that scheme, please drop us a message, and we'll definitely be welcoming taking upon the offer. And equally, if I move to the next slide, Sam. That's just how to get in touch with your governor representative. If there's any events that you think we should be doing or we could be doing more, we always welcome feedback, because as I said, we know there's more that we can do. And now that as we are able to get back out into communities more, we're really keen to see if we're meeting the needs of our community, and we do welcome everybody's input.
Kelly, thank you so much for a rich portrayal of activities that have happened over the last year since you've been the lead governor, and it's so interesting just to hear the real breadth of things that members can do and get engaged in. So by no means is it a quiet thing. If you as a member, if you want to engage in the hospital, particularly for the improvement for our patients and our staff, you've got an example of the various things that can be done there. One of the things you can do now, we've got a couple of minutes before I bring Emma in. If you have any questions or you want Kelly to elucidate a bit more on some of the stuff she's said, feel free to ask questions. I don't have any questions waiting at the moment. If there aren't any questions, what I would encourage you to do is to use the contact details that Kelly's provided in the slides, and then what I will do is go straight to Emma. So Emma Northover is our Director of Midwifery, and Emma's going to come on now and give us a spotlight on maternity services at Princess Anne Hospital. So over to you, Emma.
Thank you, and good evening to everybody. Thank you very much for having me here at your members' meeting. And yes, I'm here and delighted to share a few of the highlights around our recent CQC inspection, which happened in May this year. So this was a one-day CQC inspection, and the team came in, it was an announced visit, so we knew in advance that they would be looking to assess us around 2 of the 5 domains, and those were safety and well-led. I don't know if somebody is able to move on to the slide, that would be great. Lovely, thank you very much. So in terms of our overall rating, we were delighted that we were rated a good overall, with a requires improvement for some of the aspects around safety, and our services in terms of the world-led aspects were rated as good. The inspection team spent much of the day sort of in pockets throughout the service. They were really keen to speak to the staff across the team, as well as some of our service users. And then alongside that, they spent some time with the chair of our maternity voice partnership. And also there was an exercise in gauging some feedback from some of our service users. I think we had about just over 300 responses, which was great. So in terms of some of the things that they identified that we were doing really well, our midwifery workforce were well trained in some of the key and core aspects of care. Across the team, we're really proud that we have a shared vision, and those are really aligned for us in terms of the core values of the trust, that is putting patients first, team working and always improving. The staff were committed to managing safety events, and I would say that actually a large contributing factor to that would be around the way that it has been noted on numerous occasions that, particularly when the team are under pressure, the way they all come together and work so effectively across the team. And that really comes down to excellent communication and escalation around concerns. And then finally, around our governance structures, it was noted that we have some very strong and robust governance structures with good leadership oversight, just to ensure that the services that we are providing remain effective and safe. So some of the improvements that were identified by the team on the day, we have some challenges across the midwifery workforce. In truth, that is a shared problem across the country. I'm sure you are all very well versed on some of the challenges that maternity services are currently facing. What we know is that activity levels by nature, maternity remains an unpredictable service. So what we ensure is that at all times, we, particularly in periods of high activity and acuity, we have a process where we can ensure working through an escalation framework, which ensures that staffing resources can be released, contingency actions can be activated so that service needs can be met and patient needs can be met at any one time. In terms of the slightly longer term approach to addressing these gaps in our workforce, there's a big focus around both recruitment and retention. And some of that is now thinking of different ways and different approaches, thinking outside the box really, as well as really focusing on the people who are currently working within the service. There's a big focus on investing in our people and ensuring that we are encouraging development and openings for opportunities for career progression. Staffing challenges are also shared within the medical teams, so that was identified also, particularly around some of the education and training that some of our doctors were and weren't receiving. And in truth, it is right that we will always prioritise frontline clinical services, and during periods of high activity, as we prioritise that clinical care, it is the impact will be that on occasions education sessions will be forfeited. There were also some improvements, ongoing improvements, which we really heard and harnessed in terms of our environment and our medical equipment. So the team were very clear in terms of the safety aspects, that there were some actions that were essential and that we must do. And those have been identified and drawn out in terms of an action plan, which has executive oversight. So our Chief Nursing Officer and Maternity Safety Champion, Gail Byrne, oversees that action plan. And there are senior leads that have been associated with each of those actions, so that we ensure monitoring against continuous improvement, but also compliance around these. So to detail those out, medical staff training, as I mentioned, training was identified, and there were some gaps within the medical teams and their education and training. So to mitigate against that, what we've already done is identified some bite-sized training sessions, which allows the medical team to access those training sessions more easily. And we have arranged those at outside of normal working hours, so particularly to target those who might be working night duty or at weekends. Security was a big area of focus in terms of our within our action plan, and as a response, we put in some immediate actions to implement some security systems on reception desks, so to ensure better safety for the reception staff, but also for our service users coming in and out of ward areas. Emergency checks, those were associated with our medical equipment, and essentially there were some gaps in the checking of those pieces of equipment. So as from June, we've done the team have done a very impressive quality improvement piece of work. And as from June, we've implemented a QR code against all of our medical equipment, so that the checking of it can be audited for compliance. And actually what we have seen is a rise in our compliance levels already, which is great. Infection prevention, we are committed to ensuring that our standards of infection prevention remain as they should be. There were some areas that we identified for improvement, and so we have put in some interventions around training and education, spotlight checks and peer reviews. It's been a huge focus within the matron team to really champion that piece of work across the staff groups. And then finally, around our estates. Those of you that are familiar with the Princess Anne Hospital, the building is very well loved, but there are pockets of the area that are tired, and indeed we are outgrowing. So we are constantly looking at ways of improving our or changing our footprint to accommodate the growing needs of our service, and that piece of work is ongoing. So in terms of next steps, we are as a service really committed to continuous learning and improvement. And what I would say is actually what is fundamental to us is the notion of working together and engaging with our service users, listening to voices and listening to their feedback really brings about really rich change. And sometimes they're just small changes, but they have huge impact. So going forward, we really support the notion of collaborating with our service users, and we look forward to really really bringing that piece of work onwards. Thank you.
Thank you very much, Emma. And I think it's worth saying, just before I say this, just to remind you that you can ask Emma some questions if you have any questions for her. But I think it's worth reminding that maternity particularly has been under the spotlight now for the last 18 months, 2 years, starting with the Donna Ockenden review. We've seen Nottingham and of course the issues at the Countess of Chester recently. So so with that spotlight, we know it's been really difficult for organisations to get through a CQC inspection in relation to maternity. So I think for us in Southampton to have come out with retaining our good rating is really well done, and it's a really well done to Emma and her team and the leadership they've put in and the real focus that they have on maternity care for people using our services. So thank you very much, Emma, to you and the team. Apparently we had some questions in advance, so if you're okay, I would like to start by fielding some of those questions to you, and if we have any more that are posted now, then of course I'll pick that up. So the first one is, does the Princess Anne Hospital have a dedicated theatre for emergency caesarean sections which remains empty, so that if a patient requires an immediate section, the theatre and anaesthetic induction room is instantly available?
Yes, so I can answer that question with a yes. It absolutely does. So we have a dedicated theatre for emergency caesarean sections 24/7, which sits outside of our elective work. Gail, I don't know if you wanted to come in, yeah.
Yeah, Gail has got her hand up. So Gail, do you want to add
Yeah,
something?
no, absolutely. Emma's absolutely right. One of the things that members might have if they've been to our trust board is the discussion that we've been having on an increased elective, not emergency, but an elective caesarean rate, which has gone up to 45%. And that does put a stretch on the service, and what we do need to do is look at that in the round of services going forward, which between Emma and I we are doing, but that question could have arisen because of discussion at trust board.
Thank you very much, Gail, and thank you, Emma, for responding to that. So the next question that we received in advance was, when will the Ashurst Birth Centre be open again for births? Gail, you've still got your hand up, so I don't know if your hand up is to come in on this first. No, okay, so Emma, over to you.
Yeah, thank you. So what I would say first of all is that we are really proud of our Ashurst Birth Centre. It's a really great asset for our service, and many of you will know that during the height of the pandemic we had to review some of the services that we were delivering within the birth centre. And because of immediate needs of the service, we made the decision to centralise our staffing resources to the Princess Anne Hospital. The vision was always that this was a temporary restriction around intrapartum services, and in response, what we were keen to do was to populate the building and increase the footfall. So we moved and redeployed a lot of our antenatal and postnatal services out there, which are still up and running. It's a really hard one for me to answer in terms of timescales, but what I can do is give you my commitment around how I feel about this. When we made the difficult decision to restrict intrapartum services at the birth centre, what we realised that actually going from a system where we were open, closed, was actually not meeting anybody's needs. It wasn't meeting the needs of the staff, and it certainly wasn't meeting the needs of the public. So we were keen to pull back and review the way in which we were providing our staffing model at the New Forest Birth Centre. In truth, I think it's taken far longer than any of us initially thought, or indeed wanted, to get the birth centre back open again for intrapartum admissions. What is really clear for me is that until we can ensure safe staffing within the birth centre, that it is right to hold back and think about a different way of operating or modelling how we deliver care out at the Ashurst Birth Centre. You may or may not know that actually I came into post 18 months ago and have done a number of listening exercises, and actually what's been really useful for me is hearing the ideas and the fresh thinking about how we can actually make that reality. So what I would like to suggest is that there are no immediate plans to reopen the birth centre to intrapartum admissions, but I would like also to suggest that it will be open again in the not too distant future. I hope that answers the question.
Thank you very much, Emma. That sounded like a very detailed and heartfelt response to me, so I'm sure it responded to the question. We don't have any more questions outstanding, so what I'm going to do is to move to closing remarks. Firstly, I want to thank all of the members who registered to attend today and attended. The membership is an important part of trusts and how they're made up. And of course, retaining your interest in what we do as a hospital for our broader community, both those that we serve in Southampton and wider, is important to us. So thank you for your interest in continuing to engage with us through the various newsletters, the events that we're doing, putting people up for nomination to be the Council of Governors, etc. The second thing I wanted to say is that I'm sure you've been able to see, and I hope you'll be able to share the news that we have an amazing team of leaders here at the hospital who are very, very focused on patient involvement in their care, patient safety, and all of the things that sit around that. So you've heard for yourself, and you will have seen it in the annual report, the metrics and data that we provide. But what you've got from today is the breadth and the richness that comes through from here and from our senior leaders themselves. They're both the compassion and the commitment that they've got to retain us being a leading hospital around patient care and the things that we do. The last thing I wanted to do was just to give some thanks. So thanks again to David, to Ian, to Stephen, to Gail, and to Emma for giving up their time this evening to present today and to answer questions that have come through. And also I want to say a thank you to Samuel Dalton and the team for everything that they've done to make sure that this members evening could go ahead and to go ahead smoothly. These things aren't easy to pull together, and it's been done at a time when we've got lots of activities going on this week, including induction today for new and relatively new Council of Governors, and the annual awards, staff awards evening that we're going to have tomorrow that Kelly mentioned earlier. So despite all of that, Sam has given up time and energy and his professionalism to make sure that you as members could be briefed and participate in what I hope you'll agree has been an informative evening. So can I thank you all for giving of your time today, and to wish you all the best for the rest of the evening. And of course, I look forward to seeing those of you that are going to be there tomorrow at the Staff Awards. Thank you and good night.